India is the country with the highest TB burden, and that's not just TB. Even for MDR-TB as also HIV-TB. People with latent TB infection, it's actually half of the population or almost half of the population in our country. The national strategic plan that is given to us by the government under the revised National Tuberculosis Control Program or the National TB Elimination Program, which is now, that's what it's called. And the goal given to us was 2025. And I wanted to bring this up is because we are in 2025 and in TB and TB prevention. And some things that complete the prescription or complete our entire advice to the patient, some points that we often forget. No, there isn't an easy way to find out whether your latent TB is DS or DR.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Good evening, everyone. And before I begin, I'll just let you know that I will go through some slides in detail, and some slides are there which I will not walk through in detail. But since you can access this at a later date, you might want to just read some of them or see the algorithms in at leisure. So when we talk about current trends in management of tuberculosis, it's everywhere. We want to know what's happening in terms of epidemiology. What are some newer definitions? What are some newer classifications? What are new things in diagnosis of TB? Then quickly just understand management of TB and not just the drug sensitive TB that we are used to, but also drug resistant TB. Important concerns of liver dysfunction, kidney dysfunction on HIV-TB, and then we'll touch upon briefly upon latent TB and TB prevention. And some things that complete the prescription or complete our entire advice to the patient, some points that we often forget. So quickly understanding what the TB burden is. And I'm sure many of you are aware of this, that India is the country with the highest TB burden. And that's not just TB, even for MDR-TB as also HIV-TB. So we are a country that really has this as a major problem. And when you look at it as a state-wise prevalence, different states have different prevalence, but you will see that Maharashtra and Mumbai, from where I come from, is a high prevalence state, and this is both for TB and MDR-TB. And of course, UP, Bihar, these are other high prevalence states as well. But as you all know, there is no state or there's no city that is protected from this disease, and therefore while we see this disease in different forms, we just need to be aware of how do we manage it. So quickly about the national strategic plan that is given to us by the government under the revised National Tuberculosis Control Program or the National TB Elimination Program, which is now, that's what it's called. And the goal given to us was 2025. And I wanted to bring this up is because we are in 2025. And these goals were based on four different pillars. The first one was treat. The aim was to be able to treat at least 90% and really identify 90% of the patients with TB and treat all of them with high quality medications. And once we're able to identify and treat, then of course we will decrease the mortality and the morbidity. The other important thing is to prevent the emergence of TB in vulnerable population, and that we will touch upon when we talk about LTB and what we do to prevent and some other policy things. So before we go into the updates, I just wanted to quickly revise something that we've known about TB, because once we understand this, a lot of things do become easier. So if someone is exposed to TB, and we are right here, there are three different things that can happen. One, if the immunity is low or if the patient immunity is not able to fight it, or there's inability to control the bacteremia or the bacteria in the body, then there is immediately an active TB infection, what we call as primary TB. Some people with good immune mechanisms are able to eliminate the TB bacteria there and then. But many of them will go into what we call a latent TB phase, which means that there is an initial immune control of the bacteria to prevent it from causing an active TB infection, but it's not enough to really eliminate the bacteria from the body. And therefore, this TB bacteria is latently there in the body or latently present in the body, and it can become an active TB infection at a later point, or some people can have latent TB infection for the rest of their life, and a few will continue to eliminate TB even after that. But this is what we are worried about, is the active TB infection in the primary and the reactivation phase, as also what do we do with these people with latent TB infection. And when we say people with latent TB infection, it's actually half of the population or almost half of the population in our country. And there are certain factors that will lead to the conversion of a latent TB infection to an active TB, and some of them are listed here. But even if these are some of the factors, we know that sometimes patients will not fall into any of them, and yet they will come with a TB infection. But of course, someone with no risk factors, the risk of a latent TB going into active TB is 10% over a lifetime. In contrast, someone with TB infection and diabetes will see it's 30% over a lifetime. And someone with TB and HIV, especially HIV that's not being treated, then the TB disease is 7 to 10% per year. So it really does exponentially increase. And therefore, it's important to keep these things in mind, because if we are seeing any of these patients, it's also important to suspect TB when they present in a typical or an atypical way. So before we go into diagnosis, I just wanted to talk about certain definitions that have changed, because that has also changed the way we proceed with our tests. So this is just TB in general, and in that there is a subset of drug-resistant TB. In the drug-resistant TB is TB which is resistant to one or more drugs. In drug-resistant TB is a subset of patients which are called MDR-TB or multi-drug resistant TB. These are individuals who are resistant to both isoniazid and rifampicin. And XDR-TB are patients who are MDR, which is isoniazid and rifampicin resistant, plus resistant to the best second-line drug. And until a few years back, the best second-line drug was aminoglycoside and fluoroquinolones, and that was the definition at that point. But in 2019, some definitions or classification of the drugs changed, and that also changed the definition of pre-XDR and XDR-TB, and we'll come to that classification. So this is a very important chart. If you see, WHO reclassified all MDR-TB drugs into 3 different groups, A, B, and C, in the order of their efficacy to treat TB. So in group A is fluoroquinolones, which is moxifloxacin and levofloxacin, linezolid, and a new drug, which is Bedaquiline. These are the only 3 drugs in group A. This is for MDR-TB. In group B are cycloserine, terasidone, and clofazimine, and all the other drugs that we knew about, whether it was ethionamide, amikacin, imipenem, ethambutol, para-aminosalicylic acid, these all fall in group C. The new drug in group C is delaminib. Okay, so whenever we are making an MDR-TB regimen, we want to use 5 drugs to begin with. Therefore, we will use all group A drugs, all group B drugs, and if we cannot use any of these, then we go to group C. And I will come to this in a short while. But what I wanted to tell you is that means that the best second-line drug for MDR-TB is moxifloxacin, linezolid, and bedaquiline. And that gives us the new definition of MDR-TB. So, or XDR-TB. So, a pre-XDR-TB is an MDR-TB with additional resistance to fluoroquinolones. Unfortunately, the percentage of MDR-TBs that are going in this direction is increasing. We are seeing this more and more, especially in Bombay. And XDR-TB is MDR-TB with additional resistance to fluoroquinolones plus either linezolid and or bedaquiline. So two of the three group A drugs which are gone make it XDR-TB. So once we understand that, let's see what are the diagnostic assays we had. Okay, for the longest time or longest decades, all that we had were these first two columns. Radiology, X-ray, CT scan. In the detection of bacteria, we had smear, microscopy, and culture. But we all know that now we are really dealing with molecular assays, which have a very rapid turnaround time, and therefore that helps us diagnose TB quickly, which means that when we had to wait for 4 weeks by when the TB would have either progressed or had gone undiagnosed, now we are able to really diagnose TB within a few hours or in a day and move ahead with the best treatment possible. There is one other test which is called the TB lipoarabinomannan test, and I will touch upon that. But what I also wanted to add is that we have two interesting things that have changed. One is the use of artificial intelligence in radiology and whole genome sequencing. And honestly, this is going to be the future of TB diagnostics. Of course, we have supportive diagnostic tests like CBC, which is usually normal, but it's important to see because often these patients will have anemia. ESR, CRP are good tests because they are elevated in most of the individuals and are a cheap way or an inexpensive way to monitor patients in between our radiology or other tests that we might do. And of course, the ADA for fluids like pleural fluid, ascitic fluid, or CSF. And sometimes we might see hyponatremia if there is SIADH. And in really TB that has stayed for a very long time, we start seeing malnutrition and therefore hypoalbuminemia and hypergammaglobulinemia. And those are just findings that we need to keep in mind when we see patients. Talking about radiology, I'm sure all of you have seen a lot of patients. I'm not going to go into radiology much because this is something that we've seen, but all I wanted to just revise was different ways that the patient can present. They can present with a hydropneumothorax, miliary TB, sometimes infiltrates that really have to be looked for in the X-ray, or just a pleural effusion. This can sometimes be tricky because we will come to it that the PCR tests on pleural fluid have a low yield and therefore we might miss it. Sometimes with fibrosis in someone who's had old TB and now has a reactivation again. And if you can see, there's like a cavity developing here. So a lot of this, but what I wanted to touch upon is there are a lot of tools now, AI tools. What I've shown here is one such program called Cure.ai, where it takes the X-ray and the tool has learned to read every small finding to the point that it's become extremely sensitive and very specific. So it's a great add-on to the radiologist's eye, to the physician's eye, because at least it screens a lot of it for you and tell you that this is normal and this is what they pick up as abnormal. And then you look at the abnormal ones because the sensitivity is so high. It helps avoid a lot of confirmatory tests. Also, a lot of things that could have been missed. Sometimes X-rays are done for pre-operative evaluation or something else and would have been additionally missed and has not been looked, can be picked up. And so these AI tools are really becoming more and more helpful in our practice. Now, quickly coming to a few updates. So, of course, the most diagnostic way is to find the bacteria. So either you grow the bacteria in the culture or find the genetic material. And therefore, molecular assays have come in extremely handy and helpful. We have molecular assays and CBNAAT or GeneXpert. We have line probe assays and PCR. And what is important before we go on to diagnostics is getting a good sample, because we use all these beautiful tools, but if we've got a bad quality sample or we've just got saliva instead of sputum, then the report is going to be negative, and that will give both us and the patient a false sense that this is not TB when actually there is TB. So it's extremely important to tell the patient before even going to the assays what we'll be doing is really giving a good quality sputum. A lot of times pooling sputum really helps. It increases the yield. It almost doubles the odds of picking up TB. So giving the patient the container at home and telling them, pool the sputum and bring us the container. 3 induced sputums, in fact, some studies have shown that 3 induced sputums with hypertonic saline may be as sensitive as bronchoscopy. So that's the importance of really inducing sputum in some individuals who are unable to bring out copious sputum. And in pediatric population, sometimes we have to do gastric lavage because they're unable to bring out sputum or check their stools. This part is honestly easy because they can give another sputum again. What's really tough is the extrapulmonary sample, and a lot of times extrapulmonary samples are not collected directly by us or the patient. We often have to send the patient to the surgeon or a radiologist to get the extrapulmonary sample. And oftentimes, they will collect a sample for histopathology because TB was never suspected. It's important that when you send your note, please tell them, collect some sample in normal saline. Because any of these tests that we are going to talk about cannot be done on formalins or fixed samples. They need to be either samples in normal saline, or if they are fluid, of course, we can evaluate the fluid as well. So these are a few things that we need to keep in mind. And now we move on to the assays. Talking about CBNAT, a lot of CBNAT assays are available. TrueNAT, GeneXpert, many of them are available. They've definitely helped increase the case detection by a good percentage. They also help in not just diagnosing TB, but also tell us whether the rifampicin is sensitive or resistant, and that gives us a quick indicator of whether we are dealing with MDR-TB or no. Many of these machines also give us the bacillary load. So how in sputum we used to see +1, +2, +3, here also it gives us the load of TB. And of course, they are very sensitive and the specificity is near 100%. What's important is because these tools pick up genetic material, they cannot be used for monitoring response because even dead TB bacilli will show up positive on CBNAT tests. So these are not tests that should be used in monitoring treatment. They should be used only to diagnose the disease. So here is an example of how a report is available. You will see that there is MTB detected low, and then it will tell you whether the RIF is sensitive, RIF resistance is detected or no. The one thing I wanted to tell you is that if the MTB detected is trace, then you will get the RIF resistance as indeterminate. And indeterminate does not mean that they are resistant to rifampicin. It only means that the MTB load was so low that the machine or the test is unable to interpret the resistance. In these scenarios, if there is no history of having taken TB in the past in the individual or the family, then we do consider that as drug sensitive TB and continue treatment as drug sensitive TB and wait for the cultures. So that is one important thing I wanted to tell you about CBNAT. Of course, now we have expert MTB RIF Ultra, which is even higher sensitivity, especially in the HIV positive patients in the pediatric population, and very important in the extrapulmonary samples, because you will see that I will just show you another slide, but the yield in extrapulmonary samples can be very low. There is also an XDR cartridge now, which means that if you see that this is RIF resistant, which almost tells you that this is MDR-TB, then you go on for the next test. Again, the turnaround time is very short, but this gives you whether it's pre-XDR-TB or no, because it tells you the fluoroquinolone resistance pattern in addition to isoniazid ethionamide. So pretty much within a day or two, you will know whether the patient has TB. If it's MDR-TB, then is it a pre-XDR-TB? So when you start your treatment regimen, you're starting almost near accurate treatment regimen for the patient, which is a great help because the cultures will only come 4 to 6 weeks later. So that's another important add-on tool that we now have. This is how the reports are available, and it will tell you the isoniazid pattern, it will tell you the fluoroquinolone, and it will tell you whether they picked up any resistance to aminoglycosides or no. This is what I wanted to show you is the sensitivity of GeneXpert for extrapulmonary samples. You will see that it's pretty good for lymph nodes and even CSF, but it is very low for pleural fluids. And that's the reason why I was saying that sometimes when there is only a pleural effusion and we are trying to rely on GeneXpert to diagnose TB, it can often miss the TB because the sensitivity to CBNAT for pleural fluid is low. So please keep that in mind. Coming to line probe assays, again, these are PCR-based techniques as well. And again, very short turnaround time. The reports are available within 1 to 3 days. There are two different line probe assays, the first line probe assay and the second line probe assay. The first line tells you the resistance mutations to rifampicin and isoniazid, and the second line tells you to fluoroquinolone and aminoglycoside. So this often is like a reflex testing if CBNAT picks up any resistance. And this is just to give you an example about how line probe assay results are seen. It'll tell you what CATG, INH, what mutation was seen, and what should be inferred based on those mutations. And this is so this is someone with MDR-TB, but you can see that moxiflox and aminoglycosides are resistance is not detected. So you can really, this is pure MDR, and you don't need to give treatment as a pre-XDR-TB. Quickly coming to cultures, phenotypic drug sensitivity testing. Now we have TB MGIT. Once you see the cultures positive, we need to send for further testing, and we choose different panels on based on what we are suspecting. So there are panels that will have different drugs sensitivity testing, and there will be some that will give you all the tests. This is extremely important, especially when you're treating MDR patients. These are tests which are expensive, but they are very important to do. The cost benefit ratio weighs heavily on the side of benefit because this is a precious sample. If you in 4 or 8 weeks later you realize the patient is not responding to treatment, or the patient develops side effects to certain medications, then at least this sensitivity report tells you confidently what is the next drug that you can give. Therefore, even though these are tests that are expensive, believe me, it's we've burnt our fingers by not doing this. We must do these tests as soon as you get the culture report positive, and definitely go and check the DST for these individuals. Coming to next genome sequencing and whole genome sequencing, these are tests that are becoming more and more available, and they have the advantage that a single test picks up a lot of mutations for a lot of antibiotics. Of course, our understanding about what each of these mutation means in terms of in vivo susceptibility is growing, but for certain drugs like rifampicin, isoniazid, fluoroquinolones, even bedaquiline now, the mutations are well known, and these tests give you upfront what drugs will work and what might not work. So especially in samples like CSF, where you cannot really wait for 4 weeks or 6 weeks, these tests are very essential to improve both patient survival. Very quickly about TBLAM, it's a test that has been available across the world for a decade now. Unfortunately, something is stopping it from coming to India. But as and when it becomes available, I'll tell you where is the benefit of this drug, of this test. It's a urine test. Okay, so that means it picks up lipoarabinomenan, which is circulating and is filtered into the urine. So therefore, it's an important test for disseminated TB. It's a urine test. It's like a urine pregnancy test. You put in a drop of urine, and within 20 minutes, you have a positive or negative. Where is the importance? As you see on this graph, this is important in HIV infected individuals with CD4 less than 100. The sensitivity of this test improves. If you see, the sensitivity improves as the CD4 drops. So in individuals with a CD4 of less than 100 or even 50, you will see the sensitivity of the test to pick up TB is almost 80 to 90%. So this is a very important test for individuals who are not on ART and with low CD4 count. We hope it will become available to us soon. So to quickly summarize, whenever we collect a sample, we must collect a sample both for a molecular DST and a phenotypic DST, not either or. It has to be both because each of them has a different role. The molecular DST will tell you upfront what is the kind of TB and what is the primary drug sensitivity pattern. but the culture and sensitivity gives you the pattern for each and every drug that we can test for. And of course, do not forget to request for extrapulmonary samples in normal saline. So quickly coming to management. Okay, so if you see the diagnostic algorithm in a person with presumptive or diagnosed TB, what will happen is you will do an expert and you will see whether it's RIF resistant or it's rifampicin sensitive. So that will be available to you on CBNAAT immediately. If it is rifampicin sensitive, okay, so this is a fortunate situation to be in. Rifampicin sensitive, the next reflex testing is to do a first line LPA. Okay, in the first line LPA, it will tell you whether the isoniazid will work or not work. If it is rifampicin sensitive and isoniazid resistant, then it is a isoniazid monoresistant TB, and you have to give regimens accordingly. If it is isoniazid sensitive, rifampicin sensitive, of course, you go in for your routine isoniazid, rifampicin, pyrazinamide, ethambutol regimen. Coming to the lesser wanted scenario, in rifampicin resistant, your next test will be a second line LPA. A second line LPA or an XDR panel will tell you whether it's a fluoroquinolone sensitive TB or no. If it's a fluoroquinolone sensitive TB, we go in for a Bedaquiline based regimen. If it's a fluoroquinolone resistant TB, which is a pre-XDR TB, then we go in with a regimen which is a Bedaquiline plus delaminate based regimen. Okay, these are two newer drugs, and I will touch upon briefly upon what these regimens are. So for a completely sensitive TB, we have usually 2 months of HREZ and 6 to 8 months of HRE. The doses are written here. In TB meningitis, we want to not use ethambutol because it might not have a great CNS penetration in the later stages. And sometimes we might prefer to replace the ethambutol with an aminoglycoside. Second important thing is that the regimen in CNS and bone TB, as you know, is longer. So we go in for at least a year. Sometimes we even go for longer. Along with the TB medication in those with meningitis, we also give corticosteroids. The doses are written here. And for most patients, we follow these patients up monthly for the first 3 months, and then we can become lesser frequent. You know that the most common adverse effect of TB medications is nausea, vomiting, but the ones that are bothersome are hepatotoxicity. And 3 of these 4 drugs are hepatotoxic. And in the order of the likelihood of causing hepatotoxicity, pyrazinamide is more likely to be hepatotoxic than rifampicin, more than isoniazid. The other important pattern is that pyrazinamide often presents with transaminitis, so you will see an ALT, AST increased. In contrast, rifampicin presents more often with a cholestatic pattern, so there is a more increase of bilirubin than the transaminitis. So of course the enzymes will increase, but there will be relatively more increase in the bilirubin, and that might give you a slight idea of what your culprit medication is. Of course, to begin with, you will stop all 3 medications and then you will decide to reintroduce one after the other. The first one that you reintroduce will be isoniazid, and the second one, depending on what your suspicion, will be either rifampicin. We often do not reintroduce the third one at all if it was a severe severe hepatotoxicity. The other adverse effects are mentioned here. Remember the optic side effects in ethambutol and peripheral neuropathy in isoniazid. So those are the others that we need to remember. Coming quickly to TB medication modification in CKD and maintenance hemodialysis patients, I've enlisted it here and you can have a look at it at leisure later. But remember that thankfully isoniazid and rifampicin and fluoroquinolones require no dose adjustment, but Z and E do require dose adjustment. Coming to isoniazid monoresistant TB. So in someone who is isoniazid monoresistant, if you remember our classification, the next best drug is a fluoroquinolone. So if we cannot give isoniazid, then we will give rifampicin, pyrazinamide, ethambutol, and replace the isoniazid with a fluoroquinolone. If there is fluoroquinolone resistance, Then we replace it by linezolid and or clofazimine and cycloserine, and the order is given here. What's important to remember is that isoniazid monoresistant TBs are never treated with bedaquiline, because bedaquiline and rifampicin are never given together. But MDR-TBs, which is isoniazid and rifampicin resistant TBs, are treated with bedaquiline based regimen. Bedaquiline based regimens have been a game changer in MDR-TB management. The success rate is over 80%, which is beautiful. If the patient is compliant and the side effects are well watched for, and if you really monitored the patients well, their success rate is even higher. So, of course, this is a lengthy slide, but what I wanted to tell you is that there are certain individuals who are eligible for a shorter bedaquiline regimen, which is a 6-month intensive and a 5-month continuation phase. But most other patients require to be on a 18 to 20 month of MDR-TB regimen. I will come to a beautiful regimen that we are really waiting for, which will really cut all of this short to less than 6 months. But quickly, I wanted to show you the beauty of bedaquiline, the efficacy and the safety. It's a very safe drug. Generally, efficacy wise, you will see I've just put up the survival possibility for MDR pre-XDR and XDR-TB. The one with blue is the survival with bedaquiline, and the one with red is the survival without bedaquiline. And you will see that especially for pre-XDR and XDR-TB, bedaquiline has really given a lot of hope to people for these patients, and has really helped these patients survive and lead a very healthy life once they recover. So that's the most important and the most beautiful update in TB management for drug-resistant TB. This is a very exciting regimen that has been approved and will very soon be available in the government program, which is called the BPaLM regimen, which is for MDR-TB. It's a 6-month regimen, a completely all oral regimen. The cure rate is near 90% or more. The mortality reduction is 90%. And these drugs are drugs with very few side effects. Except for linezolid here, the other drugs are very safe drugs and don't have that many side effects. So this is something that we are really waiting for in 2025. And because these are such safe drugs, the adherence is much better. So it's called BPaLM, and I'm sure you've read about this in the newspapers. Quickly coming to the last few slides, some concerns with HIV-TB. I'm not going to go into detail of HIV-TB. It's a whole 1 hour by itself, but I'll touch upon very important things. One, HIV-TB, MDR-TB is twice as more common in this population, and so is the mortality. The diagnosis can be a challenge in this population, because if you understand, TB is an immune-mediated disease, and because these individuals are immunocompromised, the presentation is not routine. X-rays can be normal, they don't make sputum, there isn't cough. So all that they might present with is low CD4 count, not getting better, not feeling fine. And we need to keep in mind, how do we start the AKT? When do we start the ART? Very important to monitor drug-drug interactions. And these individuals where TB and HIV are diagnosed simultaneously, IRIS, or immune reconstitution inflammatory syndrome, remains a very big issue, and that needs to be managed. So to just give you the most important pointers in each of this, very important, please, in this population, we really have to actively look for TB. It has to be beyond X-ray, beyond smears, but rapid assays do come in very, very handy. The earlier practice was to delay ART until the intensive phase of TB treatment, and that is not the scenario now. There is enough evidence to show that early ART initiation has a big mortality benefit in this population. Therefore, we must attempt to start ART within 2 to 8 weeks of ATT. Earlier the better. So start anti-tuberculosis treatment, watch how things are for the next 2 or 3 weeks, and then start ART. The Best regimen in this scenario continues to be tenofovir, lamivudine, efavirenz. But now that dolutegravir based regimens are available in the public sector too, just remember that with dolutegravir, with rifampicin, you need to double the dose of dolutegravir. Okay, so for those who really practice HIV-TB, just keep that in mind. But if you didn't want to deal with doubling doses and affordability issues in the private sector of really giving two tablets of dolutegravir, then TLE or TEE as a single OD is the most ideal one. Iris is common in those who begin with lower CD4 counts, and it's important to treat these patients with low dose steroids. We will touch upon LTBI, and the adherence, of course, remains very important. So, coming quickly to LTBI, LTBI is latent TB infection. Okay, LTBI, latent TB infection. It's important so you will say, why do we need to treat LTBI? Because 30 to 40% of us do have latent TB. There are certain age groups, not certain age groups, certain population groups that are more likely to move from latent TB to active TB and have a very high TB morbidity mortality. And those are the groups that we are really trying to screen for latent TB and therefore treat for latent TBs to prevent an active TB infection. The tests that we use for latent TB is the IGRA, or the interferon gamma release assay, or the MAN2 or the tuberculin skin test, TST as we call it. That brings me to a very important point, that IGRA or MAN2 test should not be used for TB diagnosis. It's very important to remember this. Please do not use IGRA or TST to diagnose TB, because a lot of us who have latent TB do have IGRA and TST positive. It does not mean that we have active TB. It also does not mean that we really need to go in healthy individuals looking for active TB. So these IGRA and TST are tests that are used only and only to diagnose latent TB. And who are the patients who are at risk and should therefore receive TB prophylaxis? For India, every HIV infected individual, regardless of CD4, and those are also our national ART guidelines that say that irrespective of CD4 count, every HIV infected individual should receive treatment for latent TB infection. And the other three important groups are solid organ transplant candidates, close contacts of individuals with active TB, so someone in the same in the family or the household, and someone who is going to be receiving an allograft from a donor of someone with a history of untreated TB. So those are the three populations. This is just something I put up there that you can take a screenshot or access this later and see at leisure the differences between these tests for LTBI. Guidelines for TB preventive therapy. The drug that is available to us right now is isoniazid, and it is given as a single daily tablet for 6 months. Very soon, rifampicin will become available to us, and as soon as rifampicin becomes available, it will make LTBI treatment very easy, because one, it is only a 12-week course. Two, you only need to take it weekly. So instead of a daily regimen, all these people will move to a weekly regimen. So once weekly tablet for 12 weeks. Okay, and here are certain modifications of the TB preventive therapy depending on what is the drug resistance status of the TB contact. So if there is a isoniazid resistant TB, then of course we give rifampicin, and we've given a few more scenarios here. Okay, so but remember that for most of the patients, 6 months of single daily dose isoniazid is what is required. Very briefly about vaccination, because some of you might have that question. There isn't any new vaccine yet. We still have only BCG, and BCG has its benefit only in the pediatric population, where it prevents severe forms of TB in the pediatric population. It has no efficacy or limited efficacy in preventing TB in adults. And over the decades, we know that it hasn't had substantial impact on reducing global TB. But importantly, there are studies underway to check if there is a role of a booster BCG in adults and adolescents. And Some sites, even in Mumbai, are a part of this pilot, and we will have more data from this soon. And there are some other TB vaccines which are in different phases, including phase 3. So that's my last slide, is other crucial points that we really need to remember. If you have a patient with TB, irrespective of the age, gender, what you feel like, please screen every HIV patient, every TB patient for HIV and for diabetes. Please do not miss that opportunity. Do not forget to give nutritional advice. It's very important. Advise the patient and take away that, explain to the patient that it's important to mask up at least in the first 6 to 8 weeks, so that they protect their own family from TB, and tell them about good ventilation, the importance of keeping windows open, especially to prevent the TB bacilli load at home. Very important to screen household members. That is something that we often forget. And these members come to us a few months or years later with active TB. So please screen household members with an X-ray. Use this opportunity to advise regarding quitting smoking and tobacco. And patients, especially with MDR-TB and pre-XDR-TB, are very demotivated. Sometimes they've been on TB treatment for last 2 years, 3 years, 5 years, and have reached a point of actually giving up. So they require a lot of emotional support, a lot of reassurance that they are going to be fine after this newer regimen. And it requires a lot of adherence counseling, because even though it's an injection-free regimen, it is a lot of pills. Okay, so that is something that we need to do on an ongoing basis at every visit. And do not forget that we are really seeing a lot of fluoroquinolone resistance, and thanks to use of fluoroquinolones for routine fevers and URTIs. So, in fact, if there was one message all of you should take today, is stop using levoflox for URTIs and routine fevers, because a lot of these individuals have latent TB, and just 5 days or 1 week of giving fluoroquinolones makes that TB resistant to fluoroquinolone. So please spare fluoroquinolones for very well diagnosed conditions if required, and spare it for TB. Avoid empiric therapy, and we spoke about that the cost benefit ratio really is on the side of benefit. So please do not empirically treat TB. Please go right to the microbiologic, find out whether it's drug sensitive or drug resistant, and only treat then. Of course, even after making that attempt, we might fail, and then we will have to treat, but at least make that attempt. Do not forget to screen members. And you might think it's TB, and if things are not getting better, please think of things other than TB. We might be missing something else, a fungal, another diagnosis, like a histoplasmosis in an HIV infected individual. So think about the other differentials. And the last point is extremely important for us as healthcare workers. Please mask up. We are, in fact, believe me, that a lot of HIV, a lot of individual healthcare workers who come to us with TB, it's so sad that a very high percentage of them are MDR-TB, and that's because we are just so constantly in touch with these patients. So let's not put ourselves at risk. When you are seeing patients, especially patients who are coughing, mask up. Okay, so that's my last slide. And I think we have a really long way, both in ending TB and also in ending the stigma against TB. But I think a lot of this begins with us, especially the stigma against TB. And I think as a community of healthcare workers, we must play a very, very important role in stopping the stigma against TB. Make the patient and the relatives feel comfortable about the diagnosis, about wearing a mask. And tell them Amitabh Bachchan ko bhi TB hua tha. So what? It's okay. And I'm more than happy to take any questions now. Thank you so much.
Wonderful. We have a lot of questions coming in from our doctors, and we will be getting into that. I'm going to be taking one of the earlier questions that we had. It's from Dr. Kulkarni. Why cavity is very common in apical lobe only?
Yeah, so thanks for that question. So, if I could go back to my slides, but it's okay. So what I wanted to tell you is that depending on where the TB is, or whether it's primary versus secondary, primary TB is often seen in someone who is immunocompetent, and there will be a lot of immune activation or immune mechanism. Whenever there is a good immunity, there will be more destruction. And therefore, we will often see that in HIV positive individuals, we don't see cavitations because they're immunocompromised. And that's the reason why we will see it in the upper zone. And that's the most aerated areas, spaces for TB. I think there was a similar question, a very similar question, just to expand on that further. Barsha, I'm not sure if you can see it. I must have, but I had seen that question on a very similar thing come up later. Anyways, you can go ahead with the next question. Barsha, we'll come up with that question in a bit.
Yeah. So moving on to the next one. It is from Dr. Maheshwari. Sir asks, even use of 5 drugs is not effective in many persons with resistant tuberculosis.
So if we actually know the drug sensitivity, okay, so we are sure that all those 5 drugs are working, especially with the newer regimens that use linezolid and bedaquiline, we've seen a very good success rate. Of course, even after that, sometimes we don't, it's a suboptimal response, or there is, it's still not responding. There are tests available for bedaquiline resistance as well. And if that is what you are seeing, where the patients don't seem to respond even on bedaquiline, please do send the sample for bedaquiline resistance. There are quite a few labs across the country now who are doing that, as also linezolid resistance. So definitely check that. If you're talking about drug sensitive TB, oftentimes even in someone with drug sensitive TB and giving rifampicin and isoniazid, you will think everything, the doses are fine, the patient doesn't seem to respond. These are patients who must be metabolizing the drug more, rapid metabolizers. These are individuals who really benefit from increasing the dose of these medications. But before we increase the dose, we do the TDM levels, or the therapeutic drug levels of rifampicin and isoniazid, to see if the levels are lower than what we expect. And if we see those low levels, that warrants an increase in the dosage of those medications. So, Dr. Maheshwari, let me know if that answers your question. If not, just type in your question again and I'll answer it at the end.
So the next question is, Manju test is significant up to what age group, and if positive, shall we start ATT?
Oh, and I maybe this question came up before we spoke about Mantu test, but Mantu test is not a test for TB. Okay, so we do not decide TB treatment based on Mantu test at all. In fact, a lot of people who don't have any active, this has happened to us so many times, that we get a patient referred who's been started on TB treatment because of a Mantu positive, and the individuals have even got a PET CT done to look for active TB, and there is no active TB. So it really leads to so much of over investigation. So please do not base any TB treatment based on Mantu positivity. It can be positive in anyone with latent TB, and which is, like I said, a substantial percentage of the population.
So moving on to the next one, another question from Dr. Kulkarni: how to manage the patient who is resistant to secondary line ATT?
I think I just answered it. So, but to just revise it again, by second line ATT, I am believing you mean the newer drugs like bedaquiline, linezolid. So what happens is, say we begin the regimen using the first 5 most effective drugs. So group A and group B drugs, which is bedaquiline, linezolid, a fluoroquinolone, along with a cycloserine and clofazimine. So if that happens and the patient doesn't respond, or if there is a side effect, or say we pick up a resistance to clofazimine or a linezolid, then what we do is we start replacing it with drugs in group C to make it a 5 or a 6 drug regimen. But when we start adding drugs from group C, remember that they are not the most potent drugs, and therefore instead of adding 1, we might need to add 1 or 2 drugs. I hope that answers the question.
Taking the next question from Dr. Gupta: treatment of tuberculosis in compensated cirrhosis.
In compensated cirrhosis. So in compensated cirrhosis, oftentimes what we do is start with isoniazid and see how it goes. Very, very slowly. They have to be monitored very slowly, and um, with the information to the patient that you will need to monitor your LFTs often. We start with isoniazid and try to add rifampicin, and oftentimes we will just stop there. In case we can't do any of that, we can't add any of isoniazid, rifampicin, or and a pyrazinamide, then of course these are individuals who we will need to treat with the newer drugs that we spoke about, and those are pretty safe in um, those with liver dysfunction.
Next is from Dr. Datta. A child 8 years TB lymphadenitis develops ethambutol-induced optic neuritis in CP phase, so withdrawn. Is it necessary to add third drug in CP phase? If yes, then which one?
Yeah, we do get faced with that sometimes, and it's a case by case decision. If there has been great response in your intensive phase and things look pretty much resolved, you can get away with two drugs. If you're very sure you're dealing with a drug sensitive TB and you just need to replace that one drug with another drug, that drug that you will use is a fluoroquinolone. So either you're replacing isoniazid or a rifampicin or a ethambutol. The drug that we use to replace that drug is a fluoroquinolone. But keep in mind, this is if you're very sure it's a drug sensitive TB. If you're not sure if it's a drug sensitive TB, avoid doing that. Because if this is an MDR-TB that you're trying to treat, what might happen is we might convert that MDR-TB into a pre-XDR by giving her fluoroquinolone. Okay, in that case, the patient might be better off just HR and watch the patient.
So Dr. Vijay Krishnan asks, what is contact history and how long does active TB under treatment needs isolation?
So someone with active TB, and when we say active TB is a pulmonary TB who is sputum positive, often needs to be under watchful isolation for 8 weeks, around 8 weeks. Usually it takes that much time for sputum conversion. About the contact history is someone in the same household, okay, with whom they've spent substantial amount of time in the same room, and that's contact. But also keep in mind that that's an household, especially for kids who go to schools and colleges, and have spend a lot of time. It's time to ask if any of their friends have TB. What we often see is kids in grade 10 and 12, in that age group where they are in crowded coaching classes, they are doing long hours of studies and attending tuitions and don't eat well. This is kind of the age group that they really get hit with active TB. And in them, you will not get history of TB at home, but there must be someone in the friend circle.
Next is from Dr. Singh. What is the role of nutrition for TB?
Oh, very, very, very big role. Okay. It requires a high protein diet, importantly. Okay. It's a cell immune based TB, and we require the immunity to be good. So we require high protein diet. The other things that we need to keep in mind, in addition to high protein, is supplementing with vitamin D. And these are also individuals who are anemic, okay, because of the chronic disease, because they've just had loss of appetite and have not been eating well. So the other thing that we need to keep in mind is high or iron rich food or supplementing with hematinics.
Next from Dr. Saxena, how to confirm TB in pleural effusion?
So of course you will attempt a GeneXpert. You will send the sample for culture, do the ADA. Oftentimes, those with pleural effusion also have an underlying consolidation. If you can get a sputum, great. If you cannot get a sputum, I will say still definitely go ahead and bronch the patient and get the sample. Okay, it will sound very drastic, but believe me, it does help to diagnose TB versus not TB and drug sensitive versus MDR-TB. Since there are 2 minutes, and if you have 2 minutes, I can just take. I saw one or two very important questions. Someone asked me about the linezolid dose in TB. I can't find the question, but I'll quickly tell you that the linezolid dose in TB is 600 milligrams. And after 6 months, we even go to half that dose in that regimen. And I also read about someone asking me about the accessibility to the MDR-TB regimens. MDR-TB regimens are available through a lot of MDR-TB centers across the country. Every district has at least one, probably more than one, and it's easily accessible. So you'll just have to check with your district TB office where is the center, and you can refer the patients there. And these are both in public and private sector. So in both sectors, of course, the medications, even in the public sector, are for free of cost.
The next question from Dr. Saxena again. AD and LDH in effusion, what is the significance?
Yeah, they are not diagnostic, but they are like proxy markers. When you have a very high suspicion, high ADA, it's a proxy marker of the likelihood of being TB. Of course, there are false positives as well, but in the scenario of all your clinical picture, other labs, ADA is a additional marker, a supportive marker.
So next question from Dr. Sonam. Is there any way by which we can know the kind of latent TB bug one is having, DS or DR, any biomarkers on your upcoming point of care test?
Excellent question. As of now, we do not know. There isn't an easy way to find out whether your latent TB is DS or DR. And therefore, if you go back to that slide, it depends on if you can trace back the contact. If the contact had a resistant TB, then you will assume that the TB is a resistant TB. But with newer assays, it is possible that, there is a lot of research going on even doing whole genome sequencing to pick up the kind of latent TB. So maybe in the next few years, we'll even have that.
So with that, ma'am, thank you for taking the questions from our doctors. And I would also like to mention that there's a lot of positive comments for your session. Our doctors really seem to love it. Thank you once again for doing this session with us. Hope to see you soon on Medflix, ma'am.
Thank you, everyone.